All right, awesome. So next, I have the joy and honor of introducing my colleague, Jill Schofield, who is a neurologist with a special expertise in autonomic function and dysfunction and autoimmunity.
Actually, I'm an internist.
Oh, I'm so sorry. Well, she's an adopted neurologist. So internist, and do you have a presentation?
Yeah.
All right, let's get that loaded.
Yeah, I'm the only person here, I think, today whose background is in internal medicine, not neurology, and I've done kind of special multidisciplinary training to have an interest in autoimmune dysautonomia. I know we're running quite a bit behind schedule, and so I've kind of set my alarm here so that we don't get further behind. And please, if you have specific questions or focus that you want me to take, let me know. But because my background is in internal medicine, my practice is focused mostly on the cardiovascular dysautonomia. And when I use the word dysautonomia, or when other people use it, we're referring to any dysfunction of the autonomic nervous system. And I think this is a very interesting topic in the diseases that you all have, because, and I'm interested in hearing from you about whether you may have cardiovascular dysautonomia, because there's a striking paucity of literature about it. But we do know that this is a real problem in multiple sclerosis. And it may be, in fact, the initial presentation of multiple sclerosis, or it may develop later, and it causes a lot of symptoms that are potentially treatable. So that was the focus that I was going to take. This shouldn't say increasing evidence. It should say increasing interest suggests that autonomic dysregulation may be responsible for a large number of symptoms that may significantly reduce quality of life. And I recently returned from the Dysautonomia International meeting, and actually there was a lecture about this there. And the important thing, I think, in these diseases is that these manifestations are overshadowed by everything else. So you can't walk or you can't see. There's complex discussions going on about immune modulatory therapy, time spent in receiving the immune modulatory therapy, complications of it, does the therapy need to be changed? And so I think it's very unlikely that anybody's ever asked about the possibility that they might have cardiovascular dysautonomia in an MS clinic or a transverse myelitis clinic, et cetera. So let's talk a little bit about the autonomic nervous system, which is extremely complex, and really most autonomic neurologists will tell you that the textbooks are oversimplified and really need to be rewritten. But this gives us at least a good framework for a way to think about the autonomic nervous system. Really the purpose is to maintain homeostasis while we respond to internal and external demands or stressors. And it's called the autonomic nervous system because it functions automatically or without our conscious control. Autonomic nerves go to every organ, gland, and blood vessel in the body. It's extremely complex, as I mentioned, and part of the reason that we're so far behind in the autonomic nervous system is because it's difficult to study. It's very nebulous. How exactly do you study it? It's divided into two categories: the sympathetic nervous system, or the fight or flight response, and at the other end of the spectrum is the parasympathetic rest and digest system. And usually we're operating somewhere in between. Now, if there's damage, like by an autoimmune disease to the autonomic nervous system, developing this balance becomes difficult. So these are some of the things that the autonomic nervous system controls, really everything considered essential to life itself. It controls our heart rate. People with dysautonomia have significant dysregulation a lot of times in heart rate and blood pressure control. It's also responsible for controlling blood volume, and a lot of people with cardiovascular dysautonomia have significant hypovolemia. Their blood volume is too low. And sometimes they will have episodes where they have what we call polyuria, where they just start urinating too much, and it may look like water. And some people recognize that, some people don't. But when I hear people say that suggests to me they probably have autonomic dysregulation. Body temperature, sweating. People may have too much sweating, they may have too little sweating, they may be intolerant of heat, they may be intolerant of cold, they may be intolerant of both. GI dysmotility is very common. If it's affecting the esophagus, it may cause chest pain, difficulty swallowing. If it's affecting the stomach, then early satiety, nausea, which can be really very severe, difficulty eating, diarrhea alternating with constipation, bloating, and even fecal incontinence, can be seen as probably more common in transverse myelitis than what I see. Dysregulation of breathing can occur, genitourinary issues. Stress response, I think, is extremely important. And because the autonomic nervous system is intimately involved with responding to stress, when the system is diseased, then responding to any kind of stressor is impaired. And this is very much linked to functional disability, because people can even carrying on a complex conversation with somebody or coming to a doctor's appointment where you have to explain your whole history can be enough to just sort of set people back for an entire day or even a week. Responding to minor perturbations in traffic. A lot of people with significant dysautonomia are unable to drive. Sleep disturbance is common. Appetite disturbance is common. Some people with dysautonomia, they don't even have an appetite at all. They can go the whole day and not think to eat or drink. And interestingly, I see people who are hardly eating anything and they're gaining a ton of weight, and it's very, very striking. And I wonder whether it's related to the autonomic dysregulation. I suspect it is. This is an overview of the autonomic nervous system. It gives us some idea of the complexity of the system. You can see why people with transverse myelitis or neuromyelitis optica or MS may have dysautonomia, because it involves the primitive areas of the brain as well as the spinal cord. And then it goes out, as we mentioned, to every organ in the body. It is a 3-neuron system starting in the purple at the kind of headquarters in the brain, the hypothalamus. This is a primitive part of the brain that we don't really have a lot of conscious control over. That's the autonomic nervous system. And those first neurons, synapse in the autonomic nuclei in either the brainstem or the spinal cord, they then go out to the autonomic ganglia, seen in yellow, to the postganglionic neurons, which then go out to the visceral effectors, smooth muscle and lining the blood vessels, glands, heart muscle, and actually there are adipocytes, which may be related to what I was just mentioning about weight gain or weight loss. The somatic nervous system is much simpler. It's a linear system. One nerve goes to one muscle, and the autonomic nervous system is different. It's a non-linear system. If a tiger walks in the room, we need to be able to activate a whole bunch of things all at once. And this is not my slide. If it was, I would have made do I have a pointer? Do we have a pointer? If it was, I would have made that second neuron on the right go out to multiple effectors. Because so if a tiger walks in the room, we need to do a whole bunch of things. We need to shift our blood supply from the intestines, which take up a ton of blood supply, to the muscles. We need to make our heart beat faster and stronger. We need to make our pupils bigger so we can see what's going on. We need to sweat so we don't overheat. And so the system is more complicated, but that's important because when it goes wrong, a lot of symptoms occur. I like this slide because it shows sort of an overview of the whole system. Starting up, this funny-looking thing is, with the little bumps, is the hypothalamus. And this is an effector system, so everything is coming from the brain out. The autonomic nervous system is an effector system. So it starts in the primitive areas of the brain, comes down to the spinal cord. The blue neuron there is going to the autonomic ganglion, and then the red, or whatever color, the pink one, is going to the heart in this case. Other nerves are going to the blood vessels, to every organ in the body. And you can also see in this slide that there are afferent nerves returning signals to the brain about what's going on with these organs, but they're not considered part of the autonomic nervous system. And we see dysautonomia when any part of the system is screwed up. And they can actually be the same manifestations. I'm very interested in this because I'm interested in kind of multidisciplinary autoimmune disease. And when you do that, you quickly learn that pretty much every systemic autoimmune disease has been associated with dysautonomia. And that includes most, if not all, of the neurological autoimmune diseases. And so it's sort of an emerging area that these interactions between the autonomic nervous system and the immune system, the autonomic nervous system goes to every gland and organ in the body, and that includes the immune system. It has effects on the bone marrow, the spleen, lymphocytes, macrophages, and these cells actually have adrenergic and cholinergic receptors on them. So they respond to the neurotransmitters of the autonomic nervous system, in particular norepinephrine and acetylcholine. I'll show you that in the next slide in a minute. And a recent paper that came out maybe 6 months ago has suggested that autonomic dysfunction may play a role in the etiopathogenesis of rheumatoid arthritis, and that may be true for the other autoimmune diseases too. So POTS, which is a cardiovascular autonomic disorder, it may be the initial manifestation, as I mentioned, of multiple sclerosis. It may be the initial manifestation of Sjogren's syndrome or lupus or any of these autoimmune diseases, and may, like I said, be involved in the development of those diseases. And there's an interesting guy named Kevin Tracy, who's a neurosurgeon, who early in his career, he lost a very young patient to sepsis. And this caused him to develop this intense interest in the molecule tumor necrosis factor. And he was instrumental in the development of the TNF inhibitors that are used in rheumatoid arthritis and inflammatory bowel disease in particular. And so now he's latched onto this interaction between the autonomic nervous system and the immune system. And he's developed, as a neurosurgeon, vagal nerve stimulation. And he took a guy who was in, I can't remember what country, it was like Bosnia or something, where they don't have TNF inhibitors, and he treated him, who had rheumatoid arthritis, and they treated him with vagal nerve stimulation and found that his response was basically identical to as if you were treated with a TNF inhibitor. And the next slide sort of illustrates why that may be the case. So you see activation of the vagal postganglionic nerve, releasing norepinephrine, and the T cell has a receptor for norepinephrine. It's in turn activated and releases acetylcholine, which results in decreased tumor necrosis factor production from the macrophage. And so they're now using vagal nerve stimulation to treat rheumatoid arthritis and other conditions. There's a trial that was recently started at Vanderbilt University to treat this POTS, this cardiovascular autonomic disease, with vagal nerve stimulation as well. So this is sort of a hot area in the literature. This slide just shows another picture of the hypothalamus in red and the brainstem, sort of central control of the autonomic nervous system. This slide shows some of the nuclei of the hypothalamus, illustrating what we were talking about of all the different things that the autonomic nervous system controls: blood pressure, body temperature, water balance, satiety, biological clock. There is some interaction between the cerebral cortex and these central autonomic centers. In particular, you can see the limbic system, which controls our emotions, and so there is some mind-body connection, so to speak. But by and large, for the most part, the system is mostly autonomous. I think this connection has led to some centers claiming to treat dysautonomia with sort of biofeedback. And I think that works for some people, but if you have an autoimmune disease causing disease to your autonomic nervous system, those those approaches are less likely to be effective. This is just one more slide, just to show that every gland is dually innervated by the autonomic nervous system. This should provide this very fine tuning of the system. You have both an accelerator in the sympathetic system and a brake in the parasympathetic system. But this is an oversimplification, as we mentioned. And I put this slide in here to show where in the spinal cord, this is a cross-section of the spinal cord, where the autonomic cell bodies are in this intermediolateral gray columns. And so I think, as maybe Anastasia mentioned, you know, if you have transverse myelitis and there's a lesion that doesn't affect the areas of the autonomic system, then you may not have any autonomic manifestations, but many people do. And the neurotransmitters of the autonomic nervous system. So we discussed all of these different types of autonomic dysfunction already, and I'm going to focus on the cardiovascular for the reasons I mentioned. So in MS, because we don't have good data in transverse myelitis, I know that's the main thing that people here have today, ADEM and Neuromyelitis Optica, but there's very little data. There is a case report of a patient with Neuromyelitis Optica presenting with this cardiovascular condition I mentioned called POTS. We see that in MS, and the estimates are about 65% of patients with MS have some cardiovascular dysautonomia. It's very hard to say because it depends on what they use as their definition. The numbers can vary. But it causes a ton of symptoms shown here in this green box. And I'm going to try to explain how and why that happens and how and why we might be able to help these symptoms if they were recognized. So one of the important roles of the autonomic nervous system is to compensate for the assumption of an upright posture. So when we go from sitting to standing, the effect of gravity results in an immediate displacement of about 1/3 of your blood volume into the lower extremity, and this results in increased stretch in the blood vessels of the lower extremity and decreased stretch in the blood vessels of the upper extremity. And there's some autonomic fibers as part of what are called the baroreceptors you might have heard of that lead to sympathetic activation in this context. And this results in three principal things. One is tightening of the blood vessels, and this is probably the most important. The blood vessels are tightened by about 1/3. The heart rate will speed up, and the force of contractility will increase. And within about 2 beats, as you can see, the woman on the right now is the same as she was when she was sitting down, and standing for most people is seamless. You could do backflips, you could do whatever, and you should have no symptoms. In cardiovascular dysautonomia, when this system is not working right, then the person standing up is left with inadequate perfusion to their brain. And that results in most of the symptoms that we have here, lightheadedness, feeling like you're going to pass out, dizziness, chest pain, shortness of breath, heart racing, brain fog, lethargy, fatigue, weakness, all of these symptoms. And I want to talk a minute about the skeletal muscle pump because it has to do with how we test for these problems. This is a uniquely human system that contracts the muscles to compress veins and helps propel blood back to the heart when we're in an upright position. For most people who have a normal autonomic nervous system, this is a backup system for times of increased autonomic stress. So if you were in a position where you were standing all day in extreme heat and you didn't have any water, then that would be an example of increased autonomic stress. And so the skeletal muscle pump might be kicking in. And the tilt table test, I don't know if anybody's heard of this, but this is how we test formally for cardiac dysautonomia. What it does is it inhibits the skeletal muscle pump backup system. So the only way to maintain blood pressure with tilting is if there's a normally functioning autonomic nervous system. And this was introduced into clinical practice just not that long ago in 1988. resulted in an explosion of knowledge about the cardiovascular autonomic system. And basically, if somebody has dysautonomia, inhibiting their compensatory muscle pump, skeletal muscle pump will bring out the autonomic deficits. Normal people can be tilted upright all day. This test is only 80 to 90% sensitive, so if it's negative, it doesn't rule out dysautonomia. So here's an example of somebody on the left being tilted, and again, they're tilted to about 60 to 70 degrees on purpose, so they're non-weight bearing, and the skeletal muscle pump is not activated. And then the person is strapped in because sometimes this will induce syncope or passing out. This is a condition I mentioned briefly called postural tachycardia syndrome, but all of these diseases are kind of on a spectrum and they're all treated the same, and there's a few of them I'll show in a slide down a ways. But a lot of people have heard of POTS, or postural tachycardia syndrome, and this is defined as an increase in heart rate by at least 30 beats per minute in response to standing or upright tilt. And there must also be symptoms of dysautonomia or orthostatic intolerance, which we went through: lightheadedness, feeling like you're going to pass out, nausea, brain fog, and an absence of other causes for things that might cause this, like severe dehydration or severe anemia or structural heart disease. I like this slide because it's using the relatively newer technology of continuous beat-to-beat blood pressure and heart rate monitoring that's now available. And the top part of the graph shows the heart rate, and that's the most important part to look at. And so the patient is starting out with a heart rate of about 100, and then they're tilted up on the tilt table, and you can see their heart rate is increasing to about, by the end of the study, around 190 beats per minute. So they more than meet the criteria for POTS. What's interesting with this beat-to-beat technology is you can see both in the heart rate recording and the blood pressure recording that the patient with POTS has significantly more dysregulation in their blood pressure and heart rate than the control patient. And so oftentimes if we think that contributes to some of the symptoms, and if we treat with medications that can smooth out the autonomic tone, that can really be helpful. You can actually do kind of just as good as a tilt table almost at home with a stand test, a 10-minute stand test. So if you think that you might have something like this, you can lay down for a period of time, create a baseline. You can see this person I'm showing in the example has a baseline heart rate of 65. And then you can stand for varying periods of time, and it's worth doing it for about 10 minutes because for some people there's a delay in the tachycardia. And so this person, their heart rate went from 65 to 110, so they also meet the criteria for cardiac dysautonomia or postural tachycardia syndrome. This is not as sensitive as the tilt table because you still have intact your skeletal muscle pump. I like this slide because it explains why some people, they can have a normal tilt table and still have cardiovascular dysautonomia, or they can have a normal stand test and still have it, because our degrees of orthostatic intolerance can change through the day depending on stressors to the system. Now, somebody who's very sick with one of these conditions, they're going to fail the test no matter when you check them. But other people can be, pretty disabled from the problem and sometimes actually test out normal, and I've seen that many, many times. So somebody who has grade 3 or the worst, they're having orthostatic symptoms most of the time. They're kind of like living like they're walking on a tightrope. Anything can kind of tip them over. Somebody in grade 2, they're living more like they're walking on a balance beam, and it takes a little bit more to tip them over. And somebody grade 1 is more like walking on like a wooden bench. And someone with normal autonomic nervous system, you really can't knock them over, you really can't tip them over. They have their back, they have a normal system, and they also have the backup skeletal muscle pump. This lists some of the different names of cardiovascular dysautonomia, like we mentioned, and they're not really that important because they're all treated the same. So this is kind of the most important slide that I wanted to get to in case there are people here. Do any of these symptoms resonate with any of you? I think the most important ones that sort of, all the symptoms are kind of nonspecific, but the ones that kind of raise the most red flags from that green box that I mentioned back here are the feeling of lightheadedness when you stand up, feeling like you might pass out or even passing out. Tachycardia, feeling your heart racing, and exercise intolerance is very characteristic, in particular with upright exercise, because it's putting more stress on the autonomic nervous system. And intolerance of anything kind of stressful or intensive. I think those are the most characteristic symptoms that really make me think more about an autonomic disorder. Does anybody have any of those? No? Only one? My dad does. What, does he have transverse myelitis? Okay. So the first thing, because their response to standing is impaired, increasing, kind of filling up the tank, so that this lady in red, if you can increase her blood volume, that's going to help this problem. And the salt is probably much more important than the fluids, but it's the balance that's really important. As some patients will say, I'm drinking like 4 or 5 liters of water, but they're not taking any salt. And the salt is what helps hold the fluid in the blood vessels. Exercise is extremely important because people become dependent on the skeletal muscle pump. And if the muscles aren't strong, that's impaired. Exercise also increases vagal tone. And the exercise is best done in a graded fashion because, as I mentioned, upright exercise triggers symptoms. And so there are a number of protocols that are done in a kind of a graded fashion where you start strictly with recumbent exercise, and by that I mean swimming, a rower, or recumbent bike. And it's best done with a combination of aerobic exercise and, so that's our time is up, so I'll come to a close soon. Aerobic exercise and weight strengthening kind of exercises, which also should be done in the beginning. When somebody's fairly significantly affected, it should be done also in a recumbent way. And then it's a matter of slowly, gradually increasing, the time of exercise, and then going first to something like an upright bike, and then eventually transitioning to like an elliptical machine or a treadmill, or walking or running. Compression stockings and abdominal binder are helpful for some patients for obvious reasons. And I just want to mention briefly avoiding triggers, because there are actually a lot of triggers for dysautonomia, and just avoiding these triggers can be very helpful. One is just prolonged standing. So if somebody knows they're going to be standing, there are certain things like physical counter maneuvers, or crossing your legs, or raising up on your feet, even going like this. Drinking a glass of cold water beforehand, fast, can raise the blood pressure 10 points for a period of time. Anything intensive or stressful is going to make people worse, and I think Anastasia mentioned this too. Living, recognizing that there are limitations, that you have limitations, and sort of living a lifestyle that is going to allow you to do better. The people who are able to do that seem to do best. So, if you have cardiovascular dysautonomia, one of my patients took a job at Red Robin as a waitress on Friday and Saturday night, and she got worse because she's putting a ton of stress on her autonomic nervous system. And anything kind of loud, noisy, a lot of hustle and bustle is always exacerbates dysautonomia. So like going to the Broncos game or going to a concert, driving on the highway at night with a lot of cars moving fast and bright lights. For a lot of people, going to Target or any store with big fluorescent lights in a lot of people will make them worse. And kind of like migraine headaches, the triggers may not cause worsening of the symptoms right away. So if you have migraines and that are triggered by red wine, if you have a glass of red wine for dinner, you may not have a migraine until the next day or 4 in the morning or something like that. This is often the same kind of thing. So being aware of what the triggers are is very important. And then also there are a number of medications that can make this problem worse, and knowing what those are and stopping them if possible, or coming up with another regimen is helpful. And then there are another number of pharmacological agents that can be used. So I think that the bladder dysfunction, is everybody's pretty familiar with. The neurologists talk a lot about this and deal a lot about this, but I wanted to talk about the cardiovascular because I think it gets missed. And if people do have that, some of these simple lifestyle things can make a huge difference. Yeah. Well, people will get pooling in the vasculature of the abdomen as well. Actually, people get pooling in the lungs too, and that's what contributes to shortness of breath seen in these conditions. So it's kind of, so you get, just like you get pooling of blood. So the blood vessels are too loose, basically, right? The contraction of the blood vessels isn't happening when it needs to happen. And the same thing is happening in all the blood vessels in the intra-abdominal blood vessels, just as it is in the blood vessels of the lower extremities. And I was saying it also happens in the pulmonary vasculature, which has recently been shown by some researchers at the Brigham and Women's to be the cause of significant shortness of breath that we see in these disorders. So the abdominal binder, you can find them online, just Google it, and they just sort of tighten. It's like a super elastic thing that tightens, the abdomen and compresses those vessels kind of analogously to the compression stockings. Does that make sense? Nope. Well, it can. Treating all of these things that I mentioned here can help with all of these manifestations, including the shortness of breath. Some people that's their number one symptom. They're crippled by the shortness of breath. Other people, everybody has a little bit of a different phenotype, but the treatments are all pretty much the same. Thank you.